all for being here for the National Summit. And if we haven't met, my name's Drew Holzoffel, and for a brief period, I'm serving as the acting president of Us Against Alzheimer's. Wow, didn't expect that. Jason, thanks for clapping. This organization is really important to me, and I've been involved with it for about 5 years. I first met George and Trish and John and Merle and the whole team when I was at Pfizer working on a product that we thought would be the first disease-modifying drug. And when the product failed, George gave me an opportunity to continue to work on something that I care so deeply about. And that's exactly why I'm up here. I'm here to introduce somebody that unless you've been living under a rock, you know. And so I'm going to introduce George Vredenburg, who is the chairman and co-founder of Us Against Alzheimer's. We know George's connection to this disease is deep. He was brought into this world through his mother-in-law. He was brought into the Alzheimer's world through his mother-in-law. That's another conference. I don't know if you'd have more or less people, but we might try that next year. So that was back in 1992. As an indirect caregiver, George supported his wife and helped care for his mother. At the same time, he worried about Trish, his wife, getting the disease. Now he worries about his children, his grandchildren, and he worries about all of us. And that's really why he's relentless in his quest to help us find a cure. Aside from co-founding Us Against Alzheimer's in 2010, George was named to the National Alzheimer's Project Act on the Advisory Council. He's a frequent visitor and well-known on the Hill. As you saw last night at the reception, it's George's energy and interest that has driven so many of these leaders up on Capitol Hill to really care about this disease. But he's also globally known. A lot of his work is through the World Dementia Council. And with this, he's also helped lead the Global CEO Initiative on Alzheimer's Disease Forward, which is almost the private sector response to this patient-led effort in here. So without further ado, I'd like to welcome George up onto the stage.
I feel like I'm being framed.
Thank you, sir. There are more of these.
Thank you, Drew. Drew has been an extraordinary addition to this team. He's led the Global CEOI. He's on the board of the Global Alzheimer's Platform Foundation and now our acting president. So he is across the board a major force and leader in this organization on everything we do. As Drew mentioned, I got drawn into this by my wife's, my late wife's mother. Driven by the fact that her grandmother and her mother both had the disease and had been diagnosed 25 years before 1985, before 2010, when we found the organization. And in the 25 years between the time her mother had been diagnosed with the disease and 2010, we saw nothing happening. NIH funding was flat. There was no energy, there seemed to be no strategy, and we just got frustrated and wanted to change because we saw the trajectory going for Trish. My daughter, Alyssa, please stand up. My daughter is sort of the next object of my protection and affection. And my daughter-in-law, Janine Vredenburg. Stand up, Janine. So the next gen is here, folks, thank God. And with the millennials that we saw last night, the youth movement against Alzheimer's, we know the next generation is now getting engaged. So Trish and I got engaged, but we got quickly joined by two co-founders, Merrill Comer, whose husband had been diagnosed with Alzheimer's at age 58. He was the chief of hematology oncology at NIH. And now, 24 years later, he still lives at home. She has been a caregiver for him for 24 years. And 10 years ago, her mother got diagnosed with Alzheimer's, and she is in their home. So she says it with a certain sarcastic smile. She runs an Alzheimer's spa. So, and the other co-founder, John Dwyer, big Irish Catholic family, and is it 8 out of 11 of your aunts and uncles have now passed away, or in the process, and now one of his cousins has been diagnosed. So this organization started by people who really did not have sort of a scientific bent, but really were passionate about making change and disruption. And we have been joined on the board now by a number of people who, in fact, bear that same spirit and that same animation. Greg O'Brien, who's experiencing the disease, who has become our lead spokesperson as a person living with Alzheimer's and describing what it is, reporting from the mind of Alzheimer's. Jill Lesser is a sandwich generation, a mother with Alzheimer's that she's been caregiver for 10 years, and 3 rowdy boys, some moving past their teenage years, but she's done this through their teenage years. Stephanie Monroe, who you've heard before, she cared for her parent. Marilyn Glosserman, her father, and who is brings to the board a real passion for trying to find non-therapeutic approaches to solving Alzheimer's. Karen Siegel, whose mom, she has been caring for her mom now for 20-some years, am I thinking? Karen's here? No. Sean Taylor, who has taken on our Veterans Network, because her father and grandfather were diagnosed with the disease in military family, and she's now passionate about making sure that our veterans are very much included because of the increased risk experienced by those with brain-related trauma in war. And we have experts on our board. Bill Vega, who you've met yesterday, if you were here, from USC, was really extraordinarily knowledgeable, probably the nation's most knowledgeable person on the effects of this disease in the Latino community. David Satcher, former Surgeon General, who understands deeply and now personally what it is, the effects on the African American community. Nancy Zirkin, who is the former #2 person at the Leadership Council on Civil and Human Rights, who brings a social justice perspective to this effort. And of those of you who are here yesterday, the health disparities in the African American and Latino communities make this a social justice issue as well as a disease issue. So we wanted, when we got into this, to disrupt what was going on. And so what were the 3 or 4 things we wanted to disrupt? There was a point of view that said you could never get asymmetric increases at NIH for investment in any particular disease unless every disease, all boats were rising. Well, for a $6 billion cancer budget and a $400 million Alzheimer's budget, of course, when you raise the boats 10%, guess what? That's $600 million for cancer, and that's $40 million for us. And so it bore no relationship to the size and prevalence and cost of the diseases. So we wanted to disrupt that. We wanted to disrupt this notion of I'm going back a slide or trying to. We wanted to disrupt the notion that the industry isn't collaborative. There was obviously one major organization in the field, an NGO, the Alzheimer's Association, but there were hundreds of other smaller organizations or national organizations, but lesser in size. And we repeatedly heard, why can't you all get together? Why can't you all have a common mission and a common plan? So we created Leaders Engaged in Alzheimer's Disease, so ably led over the last 6 years by Ian Kremer. Now, 100 Alzheimer's-serving organizations, and another over 100 other organizations who will sign on to Lead's letters. So we have, in a collaborative way, brought those people on board. And between our Women's Network and our African American Network and our Latino Network and our Veterans Network, we are nothing if not collaborative because we are small and we are not the big organization. And finally, we wanted to fight against the notion that the only way to get at this disease and the only way that made sense to get at the disease was investing in research. Critical, necessary, but not sufficient. So let me say what the size of the problem is, at least from our perspective. Okay. Now, you're not giving me control. I hate it when I'm not in control. So what we did is we looked at the famous Al Gore charts on CO2 levels. And he points out that we are having a unique point in human history when CO2 levels are rising like a rocket. So we plotted against that the prevalence of Alzheimer's. And guess what? Unbelievable increase by 2050 around the world. And secondly, I think we have a second slide on the cost. This is a global cost. Global prevalence and costs look just like the CO2 curves. Now, there's some people who would deny the CO2 levels are rising or that there's a consequence to that and we should deny it all. But very few people will deny aging. The globe is aging, and with aging comes greater risk of Alzheimer's, and we can size that with some precision, the growth in population, aging populations, and we can size the incidence of Alzheimer's by age and cost by prevalence. This disease was identified over 100 years ago. Patients and caregivers are waiting for a strategy that beats this disease. So let me play something. I have not seen this, but I have enormous confidence in my team. They tried to whiteboard, and you'll see what a whiteboard drawing is, exactly how this organization is attacking this notion of all of the hurdles that stand in the way between research and the patient. And so let's see this.
50 million people worldwide are living with Alzheimer's disease and other dementias, and 150 million caregivers have put their lives on hold to provide high-stress, complex, and time-consuming care for those 50 million people. This disease over time robs people of their ability to remember, to think, to communicate, to feed themselves, and even to swallow. Eventually, it robs people of their lives. Alzheimer's disease was first diagnosed in 1906. More than a century later, we still don't have a cure. Patients and their families are waiting. Given the high emotional and economic toll on patients, families, caregivers, and our global economy, we can't afford to wait. That's where Us Against Alzheimer's comes in. We are innovators, conveners, and collaborators, and we are hell-bent on bringing the right people to the table to address this immense challenge in the right ways. Every day, we bring stakeholders together from across sectors like science, business, and government, along with patients, caregivers, and communities to knock down barriers that are slowing treatments and cures. Not enough understanding of the disease. Too few drugs in development, and not enough new approaches to stopping the disease. Slow, inefficient, and unrepresentative clinical trials. Inadequate government policies and regulations. Inaccessible and underutilized data. And pervasive fear and stigma. We know creating health system change to address Alzheimer's is going to take all of us. That's why we insist on an environment of collaboration, innovation, and acceleration. We're knocking down those barriers to accelerate a cure because patients and families have waited long enough. The first step is better understanding the disease. We've worked to secure unprecedented increases in NIH funding to support basic research into Alzheimer's. Knowing how the disease works can lead to fast and informed decisions that will speed up our progress. Already, with new funding, researchers are making progress on diversifying the types of treatments we are testing and finding new ways to identify the disease at its earliest stages. We now know that Alzheimer's starts to form in the brain 20 years before symptoms develop. Getting drugs into development is how we learn what works, what doesn't, and what holds promise. We're spurring investments to turn basic science into meaningful treatments to benefit people at risk. Clinical trials are how we determine what is safe and effective for people, but they can be too slow and inefficient. And this is made worse by a critical shortage of trial participants and limited capacity to take on those that are willing. That's why we launched the Global Alzheimer's Platform to accelerate and build our national capacity to test new drugs and promote participation. And we're working to diversify clinical trials through community mobilization, education, and by promoting transparency. Sometimes well-intentioned government regulations slow the path to accelerate detection and diagnosis and the pathway to clinical trial participation. They can lead healthcare providers to shy away from talking to patients about Alzheimer's, and they can slow important access to care. We're working with regulators to knock down those barriers by making changes to the rules that can have a big impact on people with Alzheimer's and caregivers. We have spearheaded legislation and worked with the administration to change this. We created AD PACE, a first-of-its-kind patient and caregiver-led collaboration that delivers new insights to researchers, regulators, and payers. We're developing innovative programs and partnerships to leverage digital technologies and big data to predict Alzheimer's through the Global CEO Initiative on Alzheimer's Disease. And through the Alzheimer's Disease Disparities Engagement Network, we're using data to map disparities and target our community outreach to those most at risk. Treatments must be found that work for everyone with the disease. We are working to develop a culture of brain health by encouraging risk reduction, early detection and diagnosis, and discussions among people and their doctors. We know that women and people of color are more likely to get Alzheimer's, so we are leaders in advancing equity and access to Alzheimer's research and resources. We are preparing the healthcare system for the day when treatments and cures are approved. We're working with the government, drug companies, insurance companies, and medical facilities to ensure the health system and payers can and will deliver treatments and care to patients who need them when they need them. Of course, at the heart of each of these areas are the patients and their families waiting for a cure. The women who make up 2/3 of the patients with Alzheimer's disease and 2/3 of all caregivers. African Americans and Latinos who are up to 2 times more likely to be diagnosed with the disease. Veterans who are at higher risk because of combat-related issues such as PTSD and traumatic brain injuries. People in low and middle-income countries who in a decade are expected to make up 63% of the people living with the disease globally. And of course, we also include the 16 million caregivers in the U.S. who sacrifice and endure along with the patients. Without patient and caregiver involvement in every step of research and care, no success will be complete. So it is with the patient in mind that Us Against Alzheimer's approaches our mission. We do our work every day with the knowledge that patients are waiting, caregivers are waiting, families are waiting, the world is waiting. We're done waiting. Join us at usagainstalzheimers.org. Take action and help accelerate an Alzheimer's cure for all.
Thank you, team. Thank you, Melissa Green, for spearheading, our communications guru, for spearheading that effort. Thank you so very much. So this is going to make the rest of this somewhat redundant, but I'm going to be very fast here. This is what's happened since we got formed. In 2010, if you took this line at the bottom left and moved it back 25 years of no change from roughly $400 million a year, and you've seen what's happened since then. So we are now, given the window that was described in that of 20 years before, there are 2 paths to preventing the symptoms of the disease. A disease-modifying drug administered before you get symptoms that slows or stops the disease progression, and non-therapeutic, that is, non-drug-related interventions in maintaining your brain health, identifying risk factors for the development of symptoms and the factors that may aggravate the speed or the onset of symptoms, and how a primary care practice can actually advise us all on the steps that we should be taking today to avoid this disease or to mitigate the timing or the occurrence of research. So two strikes at this. Let me just say that what we're going to do today, you're going to see a variety of panels that in fact are focused on everything that you've just heard, but there's going to be a good deal of focus today on the proposition of the Brain Health Initiative, because it is so important. Let me introduce our first panel, and specifically I will introduce our moderator, Behan Zaim of ASI, and I have her details here, although I've just known her as a friend and a colleague for years. Behan is the Vice President, Commercial Development and Alzheimer's Disease Global Lead in the Neurology Business Group at Eisai, Inc., the U.S. subsidiary of the global Japanese-based company Eisai Company Limited. She leads Eisai's neurology commercial development team in creating and driving commercial strategies for pipeline assets and late-stage compounds approaching commercialization stage, i.e. she's in charge of the drugs that are going to get to us soon. And of course, they recently announced some really promising results in a significant phase 2 trial of BAN2401, which is a disease-modifying drug that would be administered at the very, very earliest stage of symptomatic presentation, or potentially when we get biomarkers and other means of detecting the disease course or high risk before symptoms, administering it before symptoms appear. So she's, prior to joining Eisai 2 years ago, Ms. Zaim spent 20-plus years at Pfizer, where she had diverse global positions encompassing business development, global marketing, strategic planning, and all aspects of commercial development. It's quite a track record, quite a career. Behan, please bring your panelists up. Thank you.
Okay, George, thank you very much for that warm welcome. And thank you all for being here today. I'm sure that you're all very interested in the topic that we're about to discuss, which is the Alzheimer's disease pipeline. So before we get started, I would like to introduce our distinguished panel. And our first panelist is Dr. Kara Altemus, Associate Director at the Milken Institute Center for Strategic Philanthropy. Dr. Altemus, if you could, oh, sorry, you're coming up this way. Great, okay. Dr. Altemus advises individual philanthropists and foundations on the state of research in the areas of neuroscience and neurodegenerative disease to help them identify opportunities for giving. So also, Dr. Altemus has more than a decade of experience in neuroscience research, including neurological devices, neurodegenerative diseases, learning and memory, as well as sleep and circadian rhythm, which, as we know, is a big issue in Alzheimer's as well. And within the Milken Institute, she's led the work across the neuroscience portfolio, including recent work with the Rainwater Charitable Foundation to direct philanthropic giving for tauopathies and neurodegeneration. So really at the cutting edge and the cusp of the science. So that's wonderful. Thank you for being here. Next is Dr. Eliezer Maslaya, who I think does not need much of an introduction. Many people know him. He is the director of the National Institute on Aging's Division of Neuroscience. And as director, Dr. Maslaya is responsible for managing the portfolios and providing leadership on NIH-sponsored programs dedicated to better understanding brain aging and Alzheimer's disease in particular. His division also plays a key role in developing the research milestones for the National Plan to Address Alzheimer's Disease, which of course has the goal of finding effective ways to treat or prevent Alzheimer's disease by 2025. So welcome. I'd next like to introduce Dr. David Morgan. He is the director of the Alzheimer's Alliance and Global Impact Professor of Translational Sciences at Michigan State University. Before moving to Michigan State, Dr. Morgan served as CEO of the Bird Alzheimer's Institute at the University of South Florida, where he oversaw the development of community-based memory screening programs and this is very interesting, the country's first mobile clinical trial unit for Alzheimer's disease. That's very cool. Thank you for that. Okay, and then finally, I'd like to introduce Dr. Martin Tolar. Dr. Tolar is the founder, president, and CEO of Alzion Inc. Prior to Alzion, Dr. Tolar served as president and CEO of Nome Inc., where he led the development of human genome interpretation systems and services for academic, pharmaceutical, and clinical clients. And before that, he served as chief scientific officer and chief business officer at Comentus, where he developed the first clinical stage beta secretase inhibitor platform for Alzheimer's disease. And before that, Martin and I worked together at Pfizer for many years, so we go back a ways. So thank you all for being here today. We're really excited to have you. Before we go any further, I'd like to ask each of our panelists to share a few opening thoughts about the current state of the Alzheimer's disease drug development pipeline. So if we could start with you, Dr. Morin.
Good morning, everybody.
I think Dave, sorry.
Oh, okay.
Okay, good morning, everybody. I thought I'd start off this morning just explaining a little bit of the history of how we got to where we presently are in drug development. And it started, as you heard, 100 years ago. And it was essentially Alois Alzheimer identifying in the brain of his single patient, a woman named Auguste Deter, these abnormal, pathological appearing abnormalities in her brain, the senile plaques and the neurofibrillary tangles. And this was essentially the definition of Alzheimer's disease, and it was that way for almost the next 70 or 80 years. Finally, in the late 1970s, neurochemists came in and they started looking at the brain tissue. And based on the success in Parkinson's disease and seeing that a neurotransmitter, a chemical that communicates between cells in the brain, was deficient, one called dopamine. In Parkinson's, they found that a drug called L-Dopa that turned into dopamine in the brain was remarkably effective in treating these patients symptomatically. And so they started looking at all the other neurotransmitters in the brains of people with dementia, and they found that acetylcholine, another neurotransmitter, was relatively deficient in those brains. And this led to what we called the cholinergic hypothesis of dementia. And ultimately, in the 1990s, we developed some very effective medications in terms of boosting acetylcholine that had some marginal benefits in helping people who had cognitive dysfunctions. But later in the 1980s and early 1990s, there was another set of additions. One of them came from genetics, and the genetics has been very important to us. The first thing that happened neurochemically, though, was that we found out what made up the senile plaque. It was something we called amyloid. And what made up the neurofibrillary tangle, it was something called tau. And this then led the geneticists to start looking at those genes responsible for those proteins in order to see if we couldn't come up with a better understanding of the disease. And sure enough, we found that mutations that affected the production of the amyloid were, in familial cases of Alzheimer's disease, responsible for causing that disease. And this then focused us very hard on trying to understand what's going on with amyloid. And subsequently what's going on with tau. And because of that, we're now right on the verge of being able to develop these medications that are truly impacting those causal events in Alzheimer's disease. And I think we've started to see the first glimmers of hope from the recent clinical trials that have come out with the immunotherapies against these. But this isn't the only place we're looking now. We've also found from pathology and subsequently from genetics that inflammation in the brain, the innate immune system, is clearly playing an important role. We know that lipid metabolism is also important because of the apolipoprotein E gene and other genes that have now been linked to causing the disease. So we're really in a very positive, optimistic perspective, from my view, right now, in that we now have a whole passel of targets that we can begin to attack. And much like we treat heart disease with multiple approaches to whether it's blood pressure, whether it's lipid-lowering drugs, whether it's anti-clotting drugs, we're going to do the same thing in Alzheimer's disease. And so I for one, am very optimistic. I think we're right on the cusp of being able to have some major impact on this disease.
Thank you, Dave. Martin, do you want to? Please. Sorry. Sorry, didn't mean to cut you off. We just wanted a little. Each speaker, just to give a quick 2 to 3 minute recap of their thoughts on drug development.
Okay. So, good morning, everybody, once again. So, pleasure to be here and talk to you, and I'm giving you my perspective as a physician and drug developer. And the sad truth is that we're completely failing in changing the course of the epidemic, slowing and stopping it, where every drug that has been put in development for the past 15 years in the late stage has failed, every single one. There have been hundreds of programs that actually have failed. And while Dave is correct, we have made major advances in terms of the research. There has not been a drug that actually helped patients for 15 years. Now, George's efforts are actually very, very important because the biggest problem we have right now is to find funding for the trials. And the reason for that is that the usual stakeholders that support drug development just see the risk in drug development in Alzheimer's, which is about 1 in 200. So if you run a clinical program in Alzheimer's, you have to run 200 programs to have a chance to have one successful. That's the hard facts. So the usual stakeholders who actually support drug development, meaning pharmas, the Wall Street investors or venture investors, have all basically ran away. So most of the pharmas, with some exceptions, like Eisai, where Behan is, have exited Alzheimer's drug development. It's almost impossible to get a funding from the public investors, and it's almost impossible to get a funding from venture investors. And while there's a lot of money going into research, and Eliezer and Dave will talk about the research work, there's almost zero, and it's almost impossible to get a funding for clinical development, which meaning testing the drugs in patients. And I think that's the problem we need to address. And it's not going to come, again, it's not going to come from pharmas because they cannot, they're a for-profit organization, they have to make money, and they will not invest in a situation where you have 1 in 200 chance that something is going to work, and you're going to spend literally hundreds of millions of dollars on each of the programs. It's not going to come from the Wall Street because they need to make money, and this is not a way to make money. And it's not going to come from the venture investors who support the companies before they go public, because again, they see the risk. So we really need to figure out a way to fund studies, clinical evaluation of the treatments in Alzheimer's. That's the death valley that nobody's able to cross. There are perspective on drug development in Alzheimer's. Again, everything failed for the past 15 years. The pipeline that has been, George and I got to know each other 5 years ago at the G8 Summit. It was organized by David Cameron in London. All the world leaders showed up. And again, we talk about the same problem. At that time, maybe we had 40, 50 programs in late stage development. Now we have a handful, a literal handful. Nothing is going to get approved in the next couple of years. By 2020, there's maybe a 50-50 chance that something is going to be brought to patients by 2025. And I think that's the problem that this community has to address. And again, it's not going to come from the moneymakers, not from pharmas, not from Wall Street, not from venture investors. It has to come from government, patient advocacy groups. And again, there's a lot of funding there, but there are not obvious mechanisms to support evaluating drugs in clinical trials.
Okay, thank you, Martin. That's a real rallying cry that I think we all hear. Dr. Altemus.
Thank you, and thank you for having me here today. I'm going to provide a little bit of a different perspective from what Martin's sharing, but that's why we have a panel. So at the Milken Institute, we work really hard to help high net worth individuals and foundations invest their philanthropic capital in really impactful and unique ways. And so to do that, we really dive in to understand the science as well as the environment and what's happening in a space. And so neurodegenerative disease has been a really big area for us, which actually reflects the high level of interest from the philanthropic community over the last several years. And I would say only growing within our organization. And we've had 3 separate Alzheimer's focused projects, and the most recent one just is now, we're moving on to actually deploying funding in novel ways. In doing that, we've spent a lot of time speaking with the researchers, with other philanthropists, with pharmaceutical companies, with venture capitalists, with the small businesses. And what we have really heard time and time again is that we're in a, I think, similar to what we heard up front, we're in a place of real diversification of targets and mechanisms, and the field is moving beyond kind of one central hypothesis to many different mechanisms that we're looking at the same time. At the same time, you're right, we are seeing that, in fact, there have been some really big ones this year where large pharma have moved their neuro programs out of this, they've either dropped the neuro program or fully moved out of neurodegenerative disease. But filling that space is these new targets and smaller companies like AbbVie moving in and actually running those trials. And what we are hearing is that there's increased scrutiny for the preclinical trials, but when there's good data, there is funding. There's a bit of a tiring of some of the old trials in old ways, but there's a lot of vigor for moving on to new ideas and creating a whole shelf of neurodegenerative and Alzheimer's therapeutics. And so the last thing I'd like to say, which we'll get to in the end, is even outside of the Milken Institute and our funder pool, we've seen some really incredible philanthropic gifts to Alzheimer's just this year. So there was just the announcement from Bill and Melinda Gates Foundation for biomarker development, and that's going to be transformative, because the better we can detect and distinguish the population, the better we're going to be able to have the right therapeutics and the right people and have those successful clinical trials. So we have to build a whole toolbox, but I think the field is moving in those directions, and we are really focused. And we have so much energy from people in this room, from Congress, from the NIH, and from the philanthropic community.
Great. Thank you very much. Dr. Maslaya, please.
No, thank you very much for inviting me to be here, and thank you all for being here. I mean, I think what we're seeing here is really what motivates us to move forward and continue the work that we're doing. I've been in the Alzheimer's field for over 30 years. At the time when I was at the University of California in San Diego, we got the very first Alzheimer's Center funded by the NIH. And I mean, at that time, it was unprecedented. My mentor at the time, Bob Terry and Bob Katzman, were the first ones to bring Alzheimer's back to the center of the discussion in 1975. Prior to that, Alzheimer's was not even known, even though it was first discovered in the early 1900s. It really was not known, and even a few years ago we would have not seen what I'm seeing here today. So I'm extremely optimistic, and that's why I moved from sunny California to DC, which I love, but because of this tremendous energy and all the community coming together. I mean, I'm so excited by the work that George have done and a number of the other associations that were described, and by having a national plan. I mean, having a national plan to address Alzheimer's disease. This was signed in 2011, but just a couple of years ago we started to get some funding. We went from 400 to 500 million roughly that we have for Alzheimer's research to now 1.8 billion. And we're looking at another 400 million increase for next year. So we are just tremendously excited. And I'm also very excited by seeing the tremendous progress that has been done in the last couple of years with all the new funding that we have received. I mean, there has been tremendous progress in identifying biomarkers so we can make the diagnosis of Alzheimer's disease early enough. I mean, we're tend to think about diagnosing a disease almost at the same time that the disease process starts in the brain. But with Alzheimer's, what we have learned is that the disease process starts dozens of years before the actual symptoms appear. So try to reconceptualize that has taken a tremendous effort. So we have learned also, as Dave mentioned, a lot more about the role of inflammation. We're now learning tremendously about what is the role of aging in Alzheimer's disease. We know that it's an age-associated disorder, but for years, the role of aging was not investigated. And we know now that there are some drugs that actually delayed or stopped some of the aging process that actually have an impact on Alzheimer's disease. So I think all these progress, the progress in genetics, we have now also a new AMP program or Advanced Medicines program for Alzheimer's, so we can come up with more goals on shot for this disease. And we just recently funded a clinical trials coordinating center, so we can actually, again, accelerate recruitment, accelerate clinical trials, runs phase 1, phase 2, phase 3 clinical trials. We are currently, at NIH, we're currently funding with all the new money for Alzheimer's disease, 140 clinical trials, both these are farm and non-farm, and also more important, also including care, because it's not only about developing drugs for Alzheimer's, which at the moment we know that for those drugs to work probably we have to start very early, but also we need to think about patients with Alzheimer's disease now and about their caregivers. So we are really trying to cover a lot of ground, as I said, about 140 trials going on, so tremendous effort. But I think we're really stimulated by the energy that we see here and by all of your work, so please keep on talking to people and help us.
Thank you, everyone, for your comments. I heard a lot of optimism from all of you, and so that's and also the fact that we're talking about a multifactorial approach here. That the likelihood of any one mechanism being able to turn back this disease is low, and will require a lot of different approaches. So let me take it back to more specifics. We did have this slide up before. If I could just ask that slide to go back up, and Dr. Morgan, maybe if I could turn it to you. How would you characterize the Alzheimer's drug development pipeline today? Maybe sort of getting into some specifics so that our audience can walk out of here well-versed.
Well, first of all, I'd like to acknowledge the work of Patrick Rochelle and Drew Holzapfel, who have spent hours poring over clinicaltrials.gov and compiling a list of all the ongoing clinical trials in Alzheimer's disease. And they've been doing this every year for some time. And it's interesting to look at the year-to-year changes in this. So this is there's essentially 100 clinical trials presently going on at various stages of Alzheimer's disease and in various phases of clinical testing. And we're primarily talking about the phase 2 and phase 3 trials that are the ones that are enrolling a larger population of patients into them. And some of the changes that have been made, there's a modest increase in the number of medications being tested of about 10 to 15%. But perhaps more importantly, there's a much broader diversity of targets for these medications. For many years, it was largely just amyloid. But increasingly, we're starting to see drugs that are attacking the tau accumulation that also occurs in the brain. We're seeing some approaches that are dealing with energy metabolism, insulin, for example. We're seeing other medications that are involved in combating inflammation. We're seeing cell therapies starting to be used. And we're even on the verge of starting to see gene therapies that are being used to approach this. Certainly the ones that are presently the most optimistically likely to have a major impact are the immunotherapies. This is something that I worked on starting 20 years ago. And it's only now coming into the clinics, and we're starting to understand enough about these that we're able to target specifically the toxic proteins and not the non-toxic versions of the same protein. And that's what's giving us the success. The earlier studies with immunotherapy missed that target. They were hitting all forms of the toxic proteins. So I think what we're seeing is a big increase in not just the numbers of trials, but the big increases in the diversity, the breadth of the targets that we're going after. And we're seeing the traditional looks also at the neurotransmitters that I talked about before with the anticholinergics, working in other ways to try and boost transmission between the neurons in the brain. So I think it's really a very positive outcome, and I think the next slide actually kind of breaks that down a little bit more, right? So this is just showing you the changes from one year to the next, and you can see some of them are treating symptoms, some are treating the underlying causes of the disease, but there's, the question is how you look at a glass that has half full of water. Is it half full or half empty? And I've always been a half full guy. Now Martin, I think, is a half empty guy. But we agree on one thing. We want to fill that glass up. So
That's great.
thank you.
Maybe I'll follow
Martin,
on
you
that.
wanna
So
continue?
I would second everything has been said about the research. There's tremendous amount of research that has been done and tremendous amount of new targets. That said, if we want to change the epidemic, we have to change the course of the disease and underlying biology. There are few glimmers of hopes from the few remaining companies that are still in the game, but again, there are just few glimmers of hopes. And again, Alzheimer's is not profitable. If you talk to pharmas, if you talk to investors, Alzheimer's is not profitable. So there has to be a way for us to fund, especially, I'm not talking about the early stage research and everything. That's a few $1 million. You can find that, and actually there's plenty of money for that. I'm not even talking about some of the very early studies. Once you get to the point where you need to evaluate, does the drug works in patients? You have to run 18-month studies. It will cost you hundreds of millions of dollars. That's where you're not going to find it. And that's actually where this whole ecosystem has actually fallen apart. Again, there's tremendous understanding now of the different pathways of the stages of the disease, when you intervene and so forth. But again, we will not change the epidemic unless we have treatment that changes the course of the disease. The main risk factor, number one risk factor for Alzheimer's is age. The disease starts in most of the people in the 40s and 50s, the first changes in the brain. We have 5 million people in the US, about order of magnitude, 47 million people is estimated had initial changes in the brain, so it's every 7th person in this country. And again, unless you are able to change the basic biology, the basic underlying cause, it's just not going to change the epidemic. And again, that's the reason actually, and it's very hard, and it's very expensive. And it costs billions of dollars. The industry spent probably $20 billion on those, hundreds of studies that have been done over 15 years. And they're not willing to do that, with few exceptions. And again, unless there's a support from, this is a problem for all of us. Again, we're as a society actually going to be facing this epidemic, and we're facing it already. And unless the government is going to step up, or some advocacy groups, it's just not going to change. And I'll tell you from drug developer perspective, we have one of the few drugs that actually is going into late stage studies, and we are facing this every day.
Thanks, Martin. Let me just offer a perspective on the profitability point that you made. I think that it's fair to say it's a very high-risk endeavor, Alzheimer's research. But I do believe that the profitability equation is a positive one for pharmaceutical companies who succeed. The problem has been having the appetite for that risk. I think everyone recognizes that a successful drug would be profitable, so just a different perspective. So let's move on to the patient populations. We've talked about the fact that there are much broader targets. We've moved from amyloid to tau, neuroinflammation, other approaches, but also the patients have changed. So you hear a lot today about the need to move earlier. Bruno Dubois calls it moving to the left. So what does this mean, and what is the logic behind it? I'll leave that open to anyone who wants to start that.
Maybe I could comment a little bit about that in the context of the newly published NIA framework for Alzheimer's disease. I think what, as I mentioned before, what we have realized is that the pathological process starts much earlier than the clinical symptoms. And when we hear about all these clinical trials failing, what does it mean that they fail? Well, it essentially means that they didn't meet their primary endpoints, which by FDA definition is a clinical symptom of dementia based on a very specific testing. Now, I think that we are now beginning to recognize is that probably other endpoints could be added to that definition of the disease and to that way to evaluate if the treatment is working or not. We're currently funding at NIA at least 6 clinical trials in late stage in phase 3 that are beginning to explore precisely this question, which is that if we use these biomarkers like, for example, CSF or, cerebrospinal fluid or a brain scan, and we modify that, would that predict that if we follow those individuals with that treatment for a longer period of time, their clinical symptoms actually will be delayed or even prevented? This is something that we're beginning to work on, and now the community as a whole has got together and have made a series of very critical, very strategic decisions as to what markers are those, how should we look at them, how we conceptualize them. And what we're also very excited about is that others that were partnered like FDA and others, I mean, they are beginning also to recognize these concepts. So I think that as soon as these endpoints are recognized and we can start running the trials, and then we show that there is a connection in the very early stage between moving those biomarkers and later on clinical symptoms, I think we're going to be in a pretty good shape.
And I think that would address your point too, Martin, right, in terms of the expense of these trials. If we could just rely on a biomarker, that'd be great. They'd be much shorter.
It would be much longer, actually. If you actually want to intervene early in the disease, it would take much longer, and the prevention or the early intervention studies take actually 5 years instead of usually 3 years. But the 2 things we learned about the population: number one, the clinical symptoms, the clinical disease is actually the last stage. This is actually a huge change in thinking in the field. The disease starts about 20 years earlier. And again, so that's number one. So we need to intervene early. And in fact, actually, the glimmers of hope, the few programs that actually suggest that we can change the course, have been intervening very, very early. So not in the really, florid clinical stage of the disease, but actually in the early stage. That's number one. Number two, we learned a lot about genetics. And the first number one risk factor is age. Number 2 risk factor is what we call apolipoprotein E4 gene. Every 4th person in this room is a carrier. That means at least 1 copy of the gene. And the gene causes that you get the disease 8 years earlier if you have 1 copy, 15 years earlier if you have 2 copies. So these 2 things were probably the most profound understanding of the population. Again, the disease starts much earlier, so you have to intervene early if you want to change the course, which is really ultimately our goal. Number 2, you have to really watch for the genetics, especially the ApoE4 status, because that's completely changing the paradigm. And again, the patients get it much earlier. And that also allows us to do precision medicine approach to Alzheimer's, which is something we have started with, and now many companies are doing as well, that you focus similarly, like in a cancer playbook, you focus on the patients that have very high risk for the disease, and you can actually determine the course much, much easier.
Thanks, Martin. Kara, did you want to make a comment on that?
I did have just a very quick comment, and it combines both what Eliezer and Martin shared, but it's that this idea of being able to use biomarkers and genetics for a precision medicine approach is going to be incredibly important, because the other thing we've learned about the population of diagnosed Alzheimer's patients is that it's actually a pretty heterogeneous population when you look in their brain to see what is accumulating and what the pathological diagnosis of those patients are. And so the more precision medicine approach that we take, and I'm not remembering I'm sure Eliezer will remember the exact number, but in a postmortem study of a clinical trial, I believe that there was a finding where there were as many of the patients being treated in the experimental group that did not have Alzheimer's as there were control patients that did have Alzheimer's. And so by postmortem analysis. And so that really highlights our inability to just use clinical phenotyping to really understand what's going on in the disease, and the necessity to use biomarkers and genetic tools to understand the true genotype and phenotype of the patients.
So
I just want to add to it, just to simplify it. So what we have learned, and it's actually the third part of what we learned about a population, that in our previous studies, and if you clinically diagnose Alzheimer's, you're about 30% wrong. So the major advance now what we have is that you can look into the brain with we call PET scanning, and you can actually look at the pathology in the brain, and which addresses this problem. And it also segregates based on the genotype, as I was talking before, because in the patients who do not have the ApoE4, if you say you have Alzheimer's, you're about 40% wrong. If you look at with one copy, you're about 15% wrong, and if you have two copies, you're only 2% wrong. So that's actually the power of the precision medicine. So again, if you just sit across from the patient, you'll be almost 30% wrong, actually, and you just can't win if you run studies with this kind of population.
Great. Actually, that's a really good segue to a question to Dr. Maslaya, and then I'll get back to you. So can you talk to us? Obviously, there have been a lot of advances on biomarkers, and most notably the NIA Alzheimer's Association Research Criteria Framework. Could you talk to us about that, Dr. Maslaya? I think this was a very, very important development.
Yeah, sure. So essentially, the way we used to conceptualize Alzheimer's prior to the framework that was published this year is that the diagnosis was based on the clinical symptoms. So as Martin mentioned, that really happens in the later stages of the disease. Even when we say about somebody has mild Alzheimer's or mild dementia, really pathologically is a very late stage of the disease. And before, that's what we used to conceptualize the disease. What we said this year is like, let's separate the pathological process and the biomarkers that go with that pathological process from the clinical symptoms, and let's base the diagnosis of the disease on those pathological markers that Dave spoke at the beginning, the amyloid, the tau, and the death of the neuron, in particular the death of the connections between the neurons, and come up with a criteria that we call the ATN criteria, A for amyloid, T for tau, N for neurodegeneration or cell death of neurons, to come up with the criteria for the diagnosis of Alzheimer's disease. So if, for example, A and T are plus and N minus, that tells you that there is the Alzheimer's disease pathological process and that person is in the line of developing the disease, and that would be one approach versus is only A positive or T positive. Or for example, if it has neurodegeneration without A or T, it means that that's not Alzheimer's disease. It's some other form of neurodegeneration. So now that we have that criteria, remember this is a framework for the criteria. We have some biomarkers. Now we're going to need to test that. And we're currently funding studies precisely to test that question. We also need to develop more biomarkers. I mean, right now we have some good biomarkers for amyloid. We have some for tau, but we need to get better markers for tau. We have some markers for neuronal death, but we need better markers for neuronal death. There is a new marker for the connections in the brain that just came up for PET scan that looks very promising. But we also need markers for other proteins that are accumulating in the brain. Another thing that we have learned these years is that there is other proteins like synuclein, TDP43, etc. So we need biomarkers for those as well. So there is a lot of work that needs to be done, but I think we're again in the right trajectory.
So Dr. Altemus, just in terms of philanthropic endeavors, what do you think could be done more from that angle to spur innovation, not only in drug development, but the biomarkers that we just spoke about?
a lot. And I'll start by saying that we're publishing our Giving Smarter Guide for Alzheimer's just next week, and I brought with me some pre-printed executive summaries that I'm happy to share with anyone in the break. So for philanthropy, we just did a very extensive analysis of where we see philanthropic giving making the most impact. But in this space and in the areas of biomarkers, a couple things that we see really important at the moment is that philanthropy is really good at funding novel, very preliminary hypotheses. We did an analysis with the Rainwater Charitable Foundation giving over the last decade, and what we found is that their giving preceded NIH investment by 3 years. And what that tells you is that a little bit of money from a philanthropic source is then able to have a lot of follow-on funding from NIH, and that really kicks off a development pipeline. And so that's one really important place. Another thing that we really think about hard at the Milken Institute is that philanthropic support of biomedical research is only 5%. And we see that across spaces, and actually in our analysis of the tauopathy funding, we found that it was right at 5.5%. So really on par with what we see in other fields. And what that tells you is it can't do everything. It has to do the really specific things. So what NIH